What you're about to watch is your reminder. Listen to your body. It knows. I speak to Dr. Strong about two things I suspected were holding me back: pelvic venous insufficiency and thoracic outlet syndrome. I've got both. Pending my health, after this interview with the brilliant Dr. Sophie Strong, I will do my best to release a video discussing the results with Professor Whiteley.
We've got two proven causes, one for your arm and upper body pain and one for your pelvic pain that can be treated. And you poor girl, you've got both of them together, two curable conditions that would probably take away an awful lot of your symptoms.
You're about to watch an interview with Dr. Sophie Strong, a gynaecologist from the Whitley Clinic. We recorded this before I went for the further investigations. Dr. Stephen Smith, an American interventional radiologist, had shared striking data with me about how symptoms of conditions like POTS, orthostatic intolerance, interstitial cystitis, and ME/CFS often overlap with pelvic venous insufficiency, and how many patients improved once PVI was diagnosed and treated. It left me wondering how many others might be living with the same issue undiagnosed. I'm not a doctor or a scientist. I don't give medical advice. But I do feel a responsibility to share my journey in case it helps someone else find answers. And if it weren't for doctors like Rowe and Smith, who I jokingly refer to as Judith Switten, I might never have uncovered the connections between my condition and other chronic illnesses, including Ehlers-Danlos syndrome.
My hair always looks like it's not brushed. I mean, it's a wash, but as anyone with this illness knows, washing your hair, even at the mild end, is extraordinarily difficult. Hands above head, scrubbing, not good. Please, Sophie. Dr. Strong will sign in soon.
Dr. Strong is not late. I'm just early. Early bird catches the worm. Or, in your case, a glimpse behind the scenes. But even on a mild day, I hide a lot of pain. Hi, Dr. Sophie Strong. Lovely to meet you.
Jenny, nice to meet you too.
I've heard wonderful things about you, of course, from Professor Whiteley. If you just want to begin and introduce yourself and tell us a bit about who you are and what you do, that would be great.
So my name's Sophie Strong. I'm a consultant gynecologist with a specialist interest in pelvic pain. I have a background in endometriosis, fibroids, adenomyosis, and now more recently I'm working in pelvic congestion syndrome with Professor Whiteley as well.
Many gynecologists are not educated on this particular area, and that's a crying shame given the amount of women and men who are suffering with it. What actually made me personally investigate it was obviously my own symptoms, but more recently in reading data that shows the crossovers with orthostatic intolerance, which I do have, and dysautonomia, POTS included, overlap significantly with ME. And it also got me into reading about EDS and the potential overlaps with pelvic pain. Have you heard of any of this or read any of the data?
Running a pelvic pain clinic, I definitely see people who have been diagnosed with a lot of those conditions that you've said. I think, interestingly, all of the ones that you've just listed are the ones that have challenging diagnoses and therefore challenging management. And I think some people get labelled as one and perhaps may have the other, or can find themselves in a position where doctors simply don't know what else to diagnose with. So you might find it written in it a diagnosis of exclusion, whereby any other physical symptom cause that can be seen on a scan, cut out in surgery and looked at under a microscope. When you don't have things that are as clear cut as that, and you move into the realms of pain, which is something which is extremely complex and has a huge interlay between the physical symptoms, the mental health effects of chronic pain as well, I think it's an area that's not completely understood. And those conditions, certainly, I would say that there's overlap with all of them.
What surprises me, especially with the pain, is doctors, urologists, etc., are really fast to say that you could have this brain body pain thing where, or almost like a polite way of saying you're imagining it. I know I'm not imagining it, and I can back that up because even when they said I didn't have infections, I went and got privately tested and I did have bad infections. So I think they need to be careful before they jump to that and give you psych meds.
Definitely. And what is sad for me to hear, even in the way that you're speaking, is as if you're having to justify yourself. You shouldn't have to justify your symptoms. What you are experiencing is true. It's certainly not in your head, and it's certainly not something you're making up. Whether or not a test or a scan or a blood test or something else can pinpoint down a treatment that we have a diagnosis for and can recognize, that's a completely separate issue. And I think when it comes to particularly female health, we are lagging so far behind in the world of research for conditions like pelvic congestion or endometriosis and fibroid care, way behind other treatments that have been focused on for a lot longer and with a lot more research, money funded into it. I think it's great that people are starting to talk about pelvic pain in particular more these days, and seeing it on social media and getting the message out there that it's not normal to be crippled by pain to affect your life, or to have periods so heavy that you're flooding through your sheets at night and have to have blood transfusions. So many women are unfortunately gaslit into this being normalized, and bottom line is it's not normal.
Yeah, obviously I couldn't agree more. And during my cycle, especially, the pain can change. And I find it really bizarre that a lot of tests, whether they're blood tests or scans, it's very rarely, if at all, mentioned what point of your cycle you're in. And that led me to ask Professor Whiteley, actually, when I do go for the scan, would it be beneficial for me to be on my period? Because my pain is particularly bad around my ovulation and around my period. I also notice if I feel that I've ovulated from my left ovary, it's more painful. If I'm ovulating from my right ovary, it's slightly less painful. And when I go for the transvaginal duplex ultrasound scan, which will be performed at the Whitley Clinic under the Holdstock-Harrison protocol, I'm going to try and plan it that I'm on my period, since hearing that could be a good way to get the most accurate results.
As Professor Whiteley said, we are seeing changes at different times when you do these scans. Certainly picking a time where the pelvis might be most inflamed or have the strongest blood supply, and we're looking for a vascular issue, it makes sense that would be more under strain during those times and therefore more likely to detect that.
You do a test and it's like a snapshot, whether it's a blood test or a scan. We're human. Things change, especially women throughout the month. Physically, things change. You feel it change in you, and you can sometimes even see the changes. Boobs are bigger when you're due on. That's just an easy example. But on the subject of breasts, something I have always wanted to address. Obviously, I'm an actress. I played several parts where I wore super tight corsets. I know what it's like to take your bra off at the end of the day and it be a relief. But this is so different. I can't wear a bra for any significant amount of time. Almost like if someone held my nose or put you under the water, you're going to come up. So I'm going to take it off. And I did, through looking at pelvic venous congestion syndrome, end up finding something called thoracic
outlet syndrome. Yeah.
I've got this pain in my neck and under my arms, and I used to just say it feels like this virus or whatever's wrong with me is in the tissues in my arms and like around my rib cage. It doesn't hurt per se, but I'm wondering if A, could you have that and the pelvic issues, and B, is that something that you've ever come across or look further into?
I'll be totally honest with you. I'm sure there are many more people who are more specialised in that area to answer that particular question. Could you have two things going on at the same time? Yes. There are scans that you can have done to detect thoracic outlet. That would be something to look into separately. There is likely a lot more than what we understand going on in the body. I think we need to be humble enough to know that if there's a vascular condition in one area, it's not unlikely that something else could be affected by that. That's actually even the history of how the side from pelvic congestion came about. It was the thought that varicose veins and venous insufficiency just stopped on the visible parts of the body, which is the legs. We know that the veins come from higher up, it's just that you don't see them. And as a result of that, many people were having treatments for lower limb varicosities and not getting better or recurrence of their symptoms because they weren't going to the root and the cause of it.
Thoracic Outlet Syndrome occurs when the blood vessels or nerves between the collarbone and the first rib are compressed, causing pain, numbness, or weakness in the arms and shoulders. In bilateral cases, like mine, it affects both sides. When conservative treatments fail, surgery is often required. The most common procedure is a decompression surgery, where the first rib or surrounding tissue is removed to relieve pressure on the nerves and blood vessels. Although a vascular issue, the Whitley Clinic do not specialise in this. I will keep you posted when I find out more about who does, in case it can help anyone else.
Can we talk a little bit about the actual scan that you have to diagnose or rule out the PVCS? For a lot of patients with ME and or POTS or orthostatic intolerance, the idea of, standing up or sitting up can be, for a lot of patients, implausible plausible. And I know that for this particular scan, you do have to be at a relatively severe angle, right?
45 degrees. So that's kind of, if you imagine this would be 90, 45 is probably somewhere like that. So even as you're reclining just a little bit more than what you are now, the first thing I can definitely say is that we're there to work with you. So if you need a break or a pause or need to resume going back to, a sitting upright position or lying down a bit flatter, that's definitely something we can do to accommodate.
The Whitley Clinic certainly did accommodate me on my visit. All the clinics have a recovery area with chairs that recline. This was great, especially upon my arrival. But as anyone with ME knows, for many of us, we do need a dark room, blinds shut, and silence. Although I am lucky enough to be seeing significant improvements and a reduction of PEM, likely due to treating specific infections and modulating my immune system under Jack Lambert's regime, I can still drain fast.
I'm going to make this really quick. The lights are way too bright for me. The pelvic scan was easy enough. The leg scan, I had to stand up for parts of it. So that was really hard. This is the bed. Doesn't quite go flat enough for me, but I'm gonna
And after the scans, which were functional, I was glad I had chose the Whiteley Clinic at Bond Street in London. This is one of their spaces specifically where they said they would be able to accommodate giving me my own room if required.
I would say the sonographers there are brilliant and are very happy to work with individual patients' needs. The second is for the scan. The reason why we have you at that angle is because if you imagine if you're lying completely flat, the veins have very thin walls. So when they're not under strain or under gravity, the walls often collapse. Traditionally, when people were doing MRI scans or CT scans to look for this condition, it's not the right way to be testing it because you're not looking at when they would be dilated. And more importantly than the size of them, it's about their function. And those other tests don't tell you that. The Holdstock-Harrison protocol is specifically designed as a gold standard for diagnosing this condition. The reason for that is because not only are you assessing how the blood flows through the veins when you're not putting them under strain, but by sitting up, you're raising that gravity so that the blood pulls downwards. And essentially, this problem is where the valves that should be snapping shut inside of the veins when blood is pushed back up towards the heart aren't working properly. So each time what's happening is you get some blood pushed back in the correct direction, the doors should shut, and then when the blood falls with gravity, it shouldn't have any reflux or flowing in the wrong direction. What we're looking for is that wrong directional flow. And so by testing it with you in this 45-degree angle, we've got the effects of gravity. Then we would advise you to do a Kegel squeeze, so kind of your pelvic floor exercises, where by doing so, you're squeezing the muscles around the vasculature in that area. And again, you're putting them under the test of daily life and function and looking to see, after being stimulated and squeezed, what does the blood flow look back afterwards? Equally, we can also ask you to do something called a Valsalva maneuver. So this is where you raise your intra-abdominal pressure, and again, has a similar effect on the veins when we're looking at them for reflux. To do that, it can be sort of blowing out gas against an empty syringe, for example. Some people can feel a bit dizzy if they have that. So again, if you need to take pauses, we can take a break in between that and just work with how you're feeling. The key part of the scan to include a transvaginal scan rather than just a transabdominal scan is if you imagine the probe of the scanner is right next to these veins which we're looking at. So rather than having a gap and a distance to try to access all of the veins in the pelvis, by doing it vaginally, we have a way of being able to get really accurate diagnoses before and after treatment as well. When we're doing specific scans for varicosities in the legs, that's different, and we do get patients to stand up to do those scans. But for the pelvic investigations, actually, the best protocol rather than standing is to have you in that 45-degree angle.
And you mentioned transabdominal duplex scan. I've got written down here that might be used using the Holdstock-White protocol if no significant pelvic reflux is found and no pelvic varicose veins are identified. So is that a separate scan that you might have afterwards, or do they go hand in hand?
So hand in hand, and particularly if we're worried about some of the external compression syndromes, which are quite rare, for things such as Nutcracker Syndrome or May-Turner's. These are different conditions and they need to be managed differently as well. So it's the pelvic venous reflux disorder that we're particularly looking for, or pelvic congestion, when we've excluded the external compression syndromes for that as well.
Nutcracker syndrome occurs when the left renal vein gets compressed, usually between the abdominal aorta and the superior mesenteric artery. This can lead to symptoms like flank pain, blood in the urine, pelvic pain, and sometimes varicocele in men. May-Turner's Vascular syndrome happens when the right iliac artery compresses the left iliac vein, usually in the pelvis. This can slow blood flow and increase the risk of deep vein thrombosis in the left leg. Symptoms may include leg swelling, pain, or heaviness, especially on the left side. Personally, I have wondered if I have got Nutcracker syndrome, but as Professor Whiteley points out, not only is it very rare, it's notoriously difficult to diagnose, and a misdiagnosis can have severe consequences. I've been advised it'll be much safer and clearer to revisit my query of upstream compression, if necessary, once I've had the pelvic vein embolization. I will keep you posted as best I can, just in case my journey could help others with theirs.
So the idea is that you're having this pelvic health MOT, we call it, when you come and see us, but with the addition of my service there as my, with a gynecologist hat on, there are also key structural pointers that we might see on an ultrasound scan that could point more towards other conditions for pelvic pain, like endometriosis or seeing fibroids or adenomyosis as well.
So there are quite a lot of people with endometriosis diagnosed then that actually have pelvic venous congestion syndrome undiagnosed.
I do think there is a cohort of people who get misdiagnosed as having endometriosis, perhaps who have a spot of endo somewhere, who actually have a different underlying condition that isn't being looked for or treated. We have seen that, unfortunately, in our research from the Whitley Clinic and in our published work, where one patient had multiple laparoscopies and didn't have any significant pain improvement, where endometriosis was dealt with and cut out, and yet had a diagnosis of pelvic congestion, had treatment, and all of her symptoms resolved. Endometriosis itself, however, is just as an important condition as pelvic congestion. I'm certainly not somebody who says one is ever more than the other. It can be extremely debilitating for patients, and certainly it can be and often is the cause for a lot of people. It's just the work behind the pelvic congestion side is unfortunately lagging in the research world, even more so than endometriosis, which in itself is lagging behind other conditions in medicine. So we're here on our little soapbox trying to push things forward, but certainly being active and in the research world really is the only way to drive things forward. And that's something that we're really proud of from the Whiteley Clinic, of how academically driven and evidence-based our treatment is. We always audit our outcomes, and we are freely happy to publish them, including things when they work and also when there are complications, because no treatments are without that.
It's why I try to record meetings just to get the message out there responsibly in case it can help someone else. It's really disabling, this level of pain. It's unbelievably so.
Yeah, I can't understand it myself, but I totally acknowledge it and appreciate it. And I wish I didn't have clinics and clinics of these people suffering, looking for answers. And I think they deserve answers if there is something that we can find.
So in regards to pre-scan prep, are there any guidelines on food or drink? Do you just go? How does that work?
That bit won't affect it. So you can just attend as and when is a good time for you. In terms of times of cycle, yes, having it done whilst menstruating may be the best time for us to see something particularly there. But even if you attended outside of your cycle, if the veins are not working and they're faulty, we will see that. It's just the degree to which we see it may have some fluctuation between those two. Some people, it might not be acceptable to them to come when they're menstruating. Obviously, it doesn't bother us as healthcare providers, but some people can feel really uncomfortable about that. And I would say that shouldn't put people off coming at another time. Lots of people do attend when they're not having their period, and we still see the reflux.
And which clinic do you work at then? Because I've got a few that have been mentioned for me to potentially go to. Some are more accessible than others, and or might have somewhere for me to lie down. That's the main thing. I will need to lie down.
So I'm part of the Bond Street Clinic in London for the Whiteley Clinic, and we have a whole recovery area. We have dedicated nurses who would be able to ensure that you're safe and that we keep you as well and comfortable as possible. We wouldn't be rushing you out the door. That's not in our nature at all. Our job is to make sure that your experience and patient journey is as good as it can be. And as I say, not everybody's needs are the same.
That's great, because obviously when you have ME, and I always say I'm at the milder end of it, but my functionality is, as you can probably tell just chatting to me now, quite significantly impacted. So that's brilliant to know.
Several clinic locations are available. I recommend calling ahead to ask about accessibility. If you have ME or a condition that requires rest in a dark, quiet space after the scan, be sure to inquire about which clinic might be able to accommodate this specific need.
part of the research that I'm doing currently with the Whiteley Clinic is also to investigate the crossover of some of the other conditions I mentioned with pelvic congestion, because that hasn't been looked into yet. And I do think it's something that will be very interesting to see what the results are.
But will you look into ME as well?
If we collect data prospectively, i.e. understanding concurrent diagnoses from other patients who also have pelvic congestion, ME will be part of that. And POTS, we'll have a list of pre-existing conditions, which we can then map out into those who have pelvic congestion syndrome. It's necessary to understand where this is coming from and therefore where can you target the research to get better outcomes and treatments. I think the fact that you're having the investigation is certainly worthwhile to one way or the other know, is this something that's contributing?
If it's not and it's ruled out, at least I've got this information recorded so that some of the poor woman out there can do the same.
I know. I wish the wish for a magic wand or an injection, it would be fabulous if there was an say endometriosis injection, that it's a hormonally genetic problem and that actually at the time of being given the Gardasil, the injections for now significantly reduced rates of cervical cancer in young women, if they could also inject you at the same time with an anti-endometriosis protector, I would love to be out of a job for pelvic pain. A lot of it is going to come from the work being put in on genetic levels and understanding that. So one day.
Yeah, that's a brilliant note to sort of end on, with positivity. And actually, just off the back of that, there are so many women I know with endometriosis and endometriosis. Is that how you say it?
Adenomyosis.
Yeah, and it just seems it's more and more frequent, or it's getting diagnosed more. The money is not there for all the research to be funded properly, and that's a crying shame. But then we've got people like you, so we'll hold on to that hope.
Luckily, there are others like me as well who are really trying to promote pelvic health and management of pelvic pain.
Thank you so much. Have a lovely rest of your day.
All right, thank you. You too. Bye-bye.
And in regards to pelvic venous insufficiency, they can fix it in the majority of patients. In my next video, I'll share more details, where I discuss my results with Professor Whiteley.